Hello, and thank you for tuning in to naturemedicine.ca. Tuning in today for our webinar. We've been talking on the topic of oncotherm, one of the modalities that we do offer here at our clinic in regards to supportive care and integrative care for our oncology patients. Just an overview of what we've covered so far. We've talked in regards to the brief history of oncotherm. We talked in regards to the mechanism of action, so how oncotherm works. We then therefore started jumping into the impact of oncotherm in combination with some of the conventional treatments that are offered by your oncologist, such as the utilization of oncotherm with chemotherapy. We just concluded the utilization of oncotherm in regards to radiation. And today we're going to talk about oncotherm and the combination with some of our alternative therapies that we offer here. Namely, we're going to be focusing in on vitamin C, intravenous vitamin C. The next presentation is going to be in regards to the utilization of oncotherm and turmeric. We also want to talk about the utilization of oncotherm with low-level laser therapy in combination with some photodynamic therapy. And I might even talk about with one of the presentations that I will offer here regards to scheduling of oncotherm scheduling in regards from a perspective of our strategy and how we would put things together with oncotherm, with the low-level laser therapy, with the photodynamic therapy and the chemo and radiation. So that is something I'm contemplating of putting forward. But today we're going to talk about the impact in regards to vitamin C and oncotherm. So here's the oncotherm unit itself. If you've tuned into our past webinars, this will be looking familiar. We're going to get on through the next few slides. I just want to briefly talk on regards to the overview of the oncotherm and the impact that it has with the combination with chemo and radiation. And then we're going to jump into the vitamin C component. Now, I have also presented a webinar. It's kind of like an in-between webinar. I did want, for those of you who are not familiar with the impact of intravenous vitamin C and its role in cancer therapy, I did present and I put on a webinar in regards to intravenous vitamin C. The title is Myths and Realities, or the Truth About Antioxidants. Now, that I do feel is an important component for many of you who are not familiar with the impact of vitamin C, that if you get a chance, I would highly recommend that you look at that webinar, because that is going to uniquely tie in, and it's going to specifically tie in regards to what we are going to address today in regards to oncotherm and intravenous vitamin C. It's truly exciting, and I do feel that it's important that if you haven't already done so or not familiar with it, that check it out, because a lot of the information as we get to the meat and potatoes of today's session will really kind of tie that in. So as we can see, this being the unit, now let's move ahead. So oncotherm, based on the classical method of hyperthermia, modulated electrohyperthermia for oncological use. It's not used as a sole therapy, and typically it's combined with chemotherapy, radiation, other therapies such as intravenous vitamin C, turmeric, just to name a few. And again, if you have a chance, take a look at those previous webinars, talked about the compatibility and the utilization of oncotherm with chemo and radiation. And again, we'll briefly go over it in this session. So for those of you, you can kind of catch up while looking at the other ones, previous webinars. And for those of you who have already seen it, this will be somewhat of a familiar background information. Oncotherm, its first and only Class 3 licensed local regional hypothermia LRHT device that's approved by Health Canada. And the Health Canada medical device license number is 88986. And unfortunately, it is not FDA approved. So for my patients coming in from the United States, they do not have this opportunity to utilize it within their own country. So they are coming up to our clinic here in Nature Medicine. So it is not FDA approved. However, it is approved by Health Canada. So this is another slide kind of telling the difference in regards to oncotherm and what the average individual views hyperthermia. Now, hyperthermia typically is viewed as whole body hyperthermia, and the difference between hyperthermia and oncotherm is targeted hyperthermia. So if you take a look at the diagram to your left here, as you can see, the tumor site in and of itself with the traditional hyperthermia, the whole body is being heated. So not only does the tumor get heated, but in addition to that, you are getting increased temperature of the whole body. Whole body hypothermia, if it is being utilized, needs to be done under the supervision of an anesthesiologist. And again, you're walking that fine line and ensuring the fact that you are damaging or impacting the tumor without sacrificing the healthy tissue. Now with oncotherm, the difference is, as you saw, the equipment in the machine itself, the patient is lying on a bed, and that bed along with the probe or the head is then therefore being utilized directly on top of the tumor, and there is a radio frequency conductive component that is occurring to target the tumor. So the healthy cells are not targeted, and in essence what's happening, it is then therefore targeting the tumor cells. So it's a bit more specific in that regards here. So that's the difference between hypothermia and oncotherm. It's a play upon words. Oncotherm is hyperthermia, however it is targeted. Typically when you state hypothermia, everyone is usually viewing it from a perspective that it's whole body increased temperature, and it is used in that way. However, oncotherm is more targeted. So that's what this slide is just trying to demonstrate. This is a bit more of an idea of what to expect in regards to the oncotherm machine. As you can see, the patient is lying down, and the bed in and of itself is also acting, or where the patient is lying on. It's important that that component is part of this whole unit. That in combination with the electrode is creating the conductive component, where then therefore the tumor is being targeted. So again, oncotherm is utilized in combination with chemo, radiation, and naturopathic IV treatments. Now, typically it's administered about 2 to 3 times a week for about 4 to 6 weeks. Now, that would be one cycle. And now you're looking at trying to get anywhere from 2 to 4 cycles in. So anywhere from about 2 to 4 months. The research that I've been looking at typically is utilizing this every other day during a 5-day work week for anywhere for about 2 months to 4 months. So we're going to get into the oncotherm and the combination with chemotherapy. Again, this was talked about a bit more in depth on the webinar I presented in regards to oncotherm and chemotherapy. But there's 3 specific areas of action of how oncotherm and the combination of chemo works. Number 1, the utilization of oncotherm with chemotherapy thereby sensitizes the tumor to the chemo. The second component, it enhances the cytotoxicity of the chemo. So number 1, it allows that tumor to become that much more sensitive to the chemo. And number 2, the oncotherm will actually make that chemo that much more toxic to the tumor. And the third point, it stimulates and enhances the innate immune response, allowing the immune response to get in on the action on this whole therapy and the fight against cancer and that tumor. So now the webinar I presented on the radiation, the combination of oncotherm and radiation. It's important in radiation, well, in regards to any type of therapy that you are utilizing for the fight against cancer, it's important in regards to the cell cycle and the phase of the cell cycle. Now again, in the radiation webinar, I gave you a nice diagram on the different cell cycles, the G phase, the G naught, and so forth. So the cell cycle phase is important because radiation targets the cells that are actively dividing. And the cell cycle phase also will determine a cell's relative radiosensitivity. So the G2 to the M phase, it is the most radiosensitive, which means that that cell is actively preparing to divide. The G1 phase, it's not as sensitive. That is, if cells are in this G1 phase, the radiation is not going to be uh, as cytotoxic to that cancerous cell as it would be if it was within the G2 to the M phase. And the S phase, that is where if the cancer cell is in an S phase, the radiation therapy is not going to be as effective as it would be within the other phases here. So again, having an understanding in regards to the cell cycle. Now, you have to realize within a tumor, it's a heterogeneous component. So there are certain cells that are actively dividing. There are other components within the tumor that are not dividing as quickly or rapidly, because it all depends in regards to what phase they are in. So the mechanism of action, how does it work? Well, oncothermia will sensitize the tumor to the complementary applied radiation therapy. It increases the tumor cell oxygenation and it sensitizes the tumor to radiation. It inhibits the repair of the radiation-induced tumor cell DNA damage. So when that cell is being damaged from the radiation, the oncotherm will work in such a way that it inhibits, delays the response mechanism that the cancer cell is trying to do to repair itself. And oncotherm acts on that S phase. Now that was the phase, as you recall in the previous slide, that if the cell is in this phase, it is the least active or the least sensitive to the radiation. And now oncotherm will act on this phase, and hence what it will do, it will then therefore create more of a radiosensitive cell. So I've just talked about in regards to the oncotherm, how it works in combination with chemo. We've talked about, just a brief overview in regards to how it's working with radiation. And again, it's a bit more in depth in my previous webinars where I just dedicated it specific to that one topic. But I just want to kind of everyone on board, just give everyone a bit of a refresher and having an understanding. So we've got the chemo, we've got the radiation. So again, the brief history we discussed, the mechanism of action we discussed, we just briefly discussed in regards to the utilization with chemo and radiation. Now it's time to get in regards to oncotherm and intravenous vitamin C. We'll talk about the utilization with low-level laser therapy and overall scheduling. Now, okay, so here we go. We're going to get into this now. Again, for those of you who are not familiar in regards to the utilization of intravenous ascorbic acid or vitamin C, I would highly recommend that you view the webinar I did in regards to myths and realities about antioxidants. I'm really focused there in regards to intravenous vitamin C. So it's with that information I do want to tie in regards to the impact of oncotherm and an ascorbic acid or vitamin C. So for those who did look at that webinar, this screenshot here or this graph will look familiar. Let me see here. I'm going to get a highlighter and let's see how well this works. Okay, as you can see, the dosages of what the individuals were taking are right on that right-hand side, right? So we got 200 milligrams and upwards to 3 grams 6 times a day. So what are we trying to show here? Well, on this left side is the measurement of the vitamin C within the plasma, within the blood, okay? So as you can see here, this being at 200 milligrams taken, this is the dosage or what we are going to be able to achieve within our bloodstream. So within 5 hours, 10 hours, 15 hours, 20, so with 1 day, the concentration is approximately, let's just say about 75 micromoles. Now contrast that to the 3 grams, that box up here, taking it 6 times a day. So literally every 4 hours for one whole day at 3 grams, look at the concentration levels that we get. So you imagine taking 3,000 milligrams or 3 grams of vitamin C orally 6 times a day, every 4 hours. You're going to be able to achieve within your bloodstream, because whatever you take orally, it's got to be taken up through the GI system, filtered through the liver, and eventually it will make its way into the bloodstream. The amount that you can achieve by doing it this way is extraordinarily higher. You're looking at about 220, remember, micromoles. That's the unit that is being utilized right now for the measurement. So, well, what does that mean? Well, let's go through this. The RDA, the recommended daily allowance for an adult, is 60 milligrams. Now, well, if you just take a look at the basic that we started at 200 milligrams, 60 milligrams is really small. Now remember, the recommended daily allowance is in regards to what is the bare minimum amount an individual needs to prevent deficiency associated disorders such as scurvy here. So you got to take a bare minimum of 60 milligrams. Now, the maximum tolerance of an individual, so what happens is, well, hey, look, this individual is taking 3 grams 6 times a day. So what, 18,000, let's say. Well, I'm going to take more. Well, I'm going to take 5 grams 6 times a day. Well, what's going to happen? You're going to hit an upper limit. You can't go above and beyond this. Just because you take more, you're not going to be able to move that needle. It's going to still be hovering within this area, because anything above that, you cannot absorb any more. You will just have loose bowels, and you will it will act as a laxative. So the oral maximum tolerance is approximately, I mean, give or take, anywhere from 10 to 15,000 milligrams per day. Divided doses of approximately 3,000 every 6 hours. That's what this is showing you. So bowel saturation is achieved. Hence the reason, try it. Try to go above that. Just make sure you're close to a washroom if you decide to do that, to see if you can move that needle. You're not going to be able to. That's the maximum amount for a 60-kilogram male individual to take. Anything and above that, you'll just have diarrhea and severe abdominal cramps. Now, it's not life-threatening, it's just uncomfortable. But just because you take that, you would think that you would be able to get more in your system. No, you max out, you top out at around this maximum area right here, okay? The plasma concentration is tightly controlled at, here we go, 220 micromoles. That's what that is achieving right up here, right? So you can't go above that. 220 micromoles per liter is what we can get it at its maximum bowel tolerance level here. So this is a key point. Orally, orally vitamin C is an antioxidant, right? Antioxidants are good. It's to fight the pro-oxidants. And how many times have we heard from our oncologists stating not to take any antioxidants when receiving chemotherapy or when receiving radiation, because the chemotherapeutic agent and the radiation in and of itself is creating a lot of these reactive oxygen species, ROS, or free radicals, because in essence what they're trying to do is bombard the cancerous cells of the tumor with these toxic agents. And I'm not saying it's good or bad. It's necessary in regards to the fight against cancer and the treatment, because we need to get all hands on deck. However, what they will always tell you, they being your oncologist, if they're not necessarily enlightened in regards to the properties of vitamin C, they will always say, do not take any antioxidants while receiving these treatments, because what we want to do, we want to ensure the fact that we can maximize the therapy, the protocol that we have to fight against the cancer, because we don't want that antioxidant to negate the therapies that we're giving. Okay, so orally, this whole slide, I'm just sharing with you that at these levels, which you can't go above and beyond, you will max out at a concentration within the plasma, within the blood, at about 220 micromoles per liter, which would equate to about, what, 3 grams 6 times a day. Okay, so this is what we're looking at. All right. Now, when we get to this slide here, and again, for those who viewed my other webinar in regards to antioxidants, myth and reality, This is the slide that we really discussed and talked about in regards to the utilization of vitamin C intravenously. Now, let's go through a few points here. The biggest thing I want you to see here is on the left-hand side, and the units that are being utilized right now to measure the concentration of the vitamin C is millimoles per liter. Remember the previous slide was micromoles per liter. So what you're looking at is something that is 1,000 times greater, okay? Now on the right-hand side, this is IV vitamin C dosage. We got a gram here, upwards towards 100 grams, okay? 50 grams to 100 grams, and look at that curve right now. So at 100 grams, you're going to be peaking out at this area right here. We'll say about 15. At 50 grams, you're peaking out right around here. Okay, so what's that red line? So let's get into this. Okay, here we go. Vitamin C delivered intravenously now achieves a higher plasma level. Remember the previous slide, we talked about the oral maximum tolerance. So we said about 15,000, which would then therefore the amount of vitamin C that would be into your bloodstream will be about 220 micromoles. Because again, it has to go through the GI system and has to get filtered through the liver and eventually makes its way into the bloodstream. Well, when we utilize vitamin C intravenously, we can bypass the stomach because we are now delivering it right to the source, right to the bloodstream. So we can then therefore achieve a higher plasma level. Now, this is the interesting point here. At these levels, it is cytotoxic to cancer cells. What does that mean? It's acting as a chemotherapeutic agent. So anywhere between 11 to 22, so greater than 11, let's just focus on that. Anything greater than 11 millimoles per liter, which would then therefore be 200 milligrams per deciliter. Okay, this is the same thing. So that's what that red line is indicating. Anything above and beyond this, at this level, at 11 millimoles, the vitamin C is going to be cytotoxic. It acts as a chemotherapeutic agent. Okay, so 1 millimole is equal to 1,000 micromoles. So remember the units we were utilizing in the previous slide about the oral maximum tolerance achievable? 220 micromoles. We are now looking at something about 1,000 times greater than what you can achieve orally. That's the whole point. It's the concentration of the vitamin C, then therefore will dictate the property of that vitamin C. Orally, it is an antioxidant. Intravenously, because we can achieve levels that are much higher, it is a cytotoxic agent. So, at plasma concentrations levels that are only achievable intravenously, vitamin C is cytotoxic to cancer cells. At these concentrations, it is no longer an antioxidant, but it exerts its effects via pro-oxidation. It is a reactive oxygen species. It is acting as a chemotherapeutic agent. So it's the concentration of the vitamin C that can only be achieved intravenously, and at these levels, will that vitamin C then therefore no longer act as an antioxidant, but it will act as a reactive oxygen species. So I stress that point. That point because what are your oncologists saying? Well, specifically here in Ontario, all they say is do not take vitamin C when you're doing this chemo. It's going to negate the effectiveness of this chemo because that vitamin C is an antioxidant. But that is not the case. Not if we're utilizing the vitamin C intravenously. So that's a huge point. You understand now from what I want to gather here is it's those levels now, right? So anything above 11 millimoles per liter. Anything above and beyond that, the vitamin C is going to be acting as a chemotherapeutic agent. All right, so the safety and pharmacokinetics of high-dose intravenous ascorbic acid synergy with modulated electrohypothermia, that's the oncotherm, in Chinese patients with stage 3 and 4 non-small cell lung cancer. But that's a huge title there. Okay, so this is an article from the European Journal of Pharmaceutical Sciences, Volume 109, November the 15th, 2017. Now, if any of you are have been following in regards to these webinars, specifically in regards to the background, also in regards to the history, you will know that oncotherm is huge in Europe, huge in Asia. China and Korea are utilizing this, and we're not just saying it from a perspective of alternative therapies, it's being utilized in the hospital setting there. So a lot of the research is coming from there right now. So 2017, what they wanted to do is, well, hold on. Hey, we've been seeing some studies in regards to what oncotherm can do with radiation. We've taken a look at the studies that are out there for oncotherm and chemotherapy, but has anyone done anything with oncotherm with this alternative therapy, vitamin C? And that's what this paper is talking about. So I want to kind of go through some of the key points here. So let's understand in regards to what was going on with this trial. Well, a clinical trial to evaluate the safety and the pharmacokinetics, the action, in patients with stage 3 and 4 non-small cell lung cancer. Now, stage 3, stage 4, it's unfortunately a dire situation for that patient. Most of these patients were selected because there was no other treatment available for them. And that is why they decided to see the impact of oncotherm and intravenous vitamin C. Now, the patients were randomized or allocated into 3 groups, and they received doses of 1.2, and 1.5 grams per kilogram of ascorbic acid or vitamin C infusion. This process was applied 3 times a week, basically every other day with the weekends off, for about 4 weeks. So they're broken down into 3 groups. The first group received intravenous ascorbic acid when the hyperthermia or the oncotherm machine was finished. So that's group A. So what ended up happening is they would then therefore get the oncotherm first, and when that was completed, they received the intravenous vitamin C. That's the first group. Now the second group, group B, the intravenous vitamin C was administered at the same time with the oncotherm. So that's group B. Group B, they were administered at the same time. Now, group C, what was happening is the third group, intravenous ascorbic acid, was applied first. So the IV was applied, then when the IV was completed, that's when it was followed up with the oncotherm. So you got group A, group B, and group C. All of them receiving intravenous vitamin C, all of them receiving oncotherm, but it was also the key component is it better to receive the oncotherm before the intravenous vitamin C, during the intravenous vitamin C, or after the intravenous vitamin C? Okay, so now this slide here is the graph of group A, group B, and group C. Now let's go through this. I'm gonna get my highlighter, and on the left side is exact same, the plasma concentration, so the amount of vitamin C in the blood, and it's being measured at millimoles per liter. Remember the cutoff, we said anything above 11. So anything around this area here, the vitamin C is going to be acting as a chemotherapeutic agent. So as you can see down here, for one day they received 1 gram, the next day they received 1.2 grams per kilogram of body weight, don't forget. And the third time they received 1.5 grams per kilogram of body weight. Now, as you can see here on the right side, you see Sol A. What does that mean? They just received vitamin C. If you see Sol B, just received vitamin C, and Sol C received vitamin C. And as you can see, all of those curves in that graph, they're pretty much all the same, right? Because they just received vitamin C. Whether it was but I guess the other point I want to share with you is, look, even just receiving vitamin C, you're able to achieve something that is chemotherapeutic. It's going to have an impact on the cancer cells. It's above that 11. Obviously, at 1.2, it's going to be higher, and at 1.5, it's going to be the highest. Now, this is the key point here. Now, if you take a look at combined A, what was A? Remember, it was the oncotherm was done first, and then followed up with a vitamin C. That was combined A. And combined C was, well, vitamin C was done first, then the oncotherm was done. And if you notice there's no difference within the curve. The only thing that you see really popping out is this combined B, that purple one you see. Well, the combined B, remember, that was where the vitamin C and the oncotherm were done simultaneously. That's the only difference. And if you take a look there, even at the same dosage point at 1 gram, if you do 1 gram per kilogram of body weight and you combine it with the oncotherm, look at what you achieve. Much higher. This is just at 1 gram. At 15 millimoles. Remember, we want to get something above 11. Everything else was the same. Whether if you did the oncotherm before or after the vitamin C, it was no different than just doing vitamin C on its own. But if you do the vitamin C in combination with the oncotherm, you can achieve plasma levels higher than on its own. And that's the whole point. So you can now see how oncotherm and the utilization with the alternative therapy such as vitamin C, you can have that much more of an impact here. At 1.2, we're achieving now 20. At 1.5, you're achieving 25. You have more of a kill factor. Yes, obviously, if you were to do vitamin C on its own, you will be able to achieve a higher rate. That is for sure. But now you combine that with the oncotherm, now you look at the impact that you can have. So, the intravenous ascorbic acid, vitamin C, before or after the oncotherm shows the same results and does not differ between the utilization of just the intravenous vitamin C on its own. That was treatment groups A and C. There's no difference. So conclude that the concomitant application of oncotherm along with intravenous vitamin C, which is group B, increases the plasma concentration of ascorbic acid in comparison to it being utilized on its own or if it's utilized before or after. So to summarize, among the 3 groups, peak concentration of ascorbic acid was significantly higher in group B than in the other 2 groups, while other ascorbic acid concentration time profiles showed no significant differences between the groups, right? If it was just utilized on its own. And that's the huge component and the point that I really want to stress with today's webinar. So hopefully through this, you're able to have a better understanding and how to combine the use of alternative therapies. I think it's the key component is 1 + 1 doesn't necessarily give you 2. 1 + 1 may give you 5. Now, with all of this information, it's important then therefore you go to see someone who is qualified in utilizing these strategies, whether the patient is receiving chemo. Hey, maybe the chemo is once every 3 weeks. Well, we have the 2 weeks in between that we can continue utilizing a component of therapy to have an impact on that tumor in and of itself. So as you can see now, exciting news in regards to oncotherm and one of the time and tested therapies such as intravenous vitamin C. So I thank everyone for tuning in, and this does conclude in regards to today's webinar. Stay tuned for more to come on board. Until then, everyone take care.